More about you. You're the cancer advocacy. We are from United States, and I lived most of my life here in the States. And the one thing we don't know much about South Africa, that we know that apartheid was there, Nelson Mandela. That's all we know. We don't know much about healthcare system there, and we have not much of a education in that area. So you can give us a little exposure on that area. So give us a little bit about your background, Salome.
And very good morning to everybody there in Silicon Valley. I'm happy and thank you for the invitation. So, yeah, I trained as a medical social worker many years ago and worked in community development for more than 15 years. And that was my foundation for the value and importance of civil society participation in change. Effective social change in communities can only happen if there is meaningful participation by the very people who are affected. So, more than 25 years ago, my best friend passed away from breast cancer at the age of 37 and leaving behind a 2.5-year-old daughter. And I was at the height of my professional career and was faced with the question, what is your purpose in life? And this allowed me to refocus. And I gave up the security of a paying job to live my own life then with purpose by making a meaningful change in cancer care. And I know that about myself. I do not do well on an individual one-on-one care or even group work. One of my professors at university already warned me that my talents are in change and in community development. And it's also linked to my parents who allowed me to grow up with a very strong will and to believe in myself. So I'm fortunate also that my life partner supported my decision to be actively involved in cancer care change. And over the years has walked many of the very rough roads with me. So I started off in an advisory capacity, training cancer nonprofits in the developmental focus of cancer care. And that led to my role as an advocate for policy change, focusing on cancer registration, national cancer control, and a dedicated cancer policies and access to affordable medicines. With my exposure to the archaic patent law in South Africa, I became aware of the injustice of our own legal framework that does not allow for people to have equitable access to essential medicines, such as trastuzumab for breast cancer, lenalidomide for multiple myeloma, and bendamustine for non-Hodgkin's lymphoma. And this is despite a very, very bold constitution that recognizes health as a human right. Nelson Mandela said, where you live should not determine whether you live. So I was introduced to the Treatment Action Campaign and Section 27, and that was my entry point in cancer activism. Health is a basic human right, and we need to bring the need for comprehensive, timeous cancer care to the attention of governments. This is a discussion that includes patients because we say nothing about us without us. It's not a business deal. No, it's a patient public private partnerships. And that is what we say we need to rethink, redesign, re engineer cancer care, and cancer patients and their families needs to stand up and speak up for their health rights.
Salome, before you jump into the cancer care, just give us a 30,000 foot idea about the South African healthcare system. Is it like a private and public parallel systems exist, right? Just what I little bit I know about the South African healthcare system. You have a public healthcare system and a private healthcare system parallel together. Is that
Correct. So what we have is we've got 84% of the public sector of the people in in the public sector that access the public sector, 84% of the population. And then the 16% goes to the private sector. But if we then look at what are the facilities as well as the healthcare professionals, you will find it is the turnaround. So you've got 80% of healthcare professionals, as well as your equipment and facilities that service 16% of the population. And that is the absolute inequity of healthcare services in South Africa.
So it is besides that you have a serious shortage of doctors and nurses also. That is that South Africa is struggling with that process, and then rural areas doctors, that is also a big challenge for you all in South Africa, right?
We do have a shortage of doctors. On the one hand, yes, there's a shortage. We've got brilliant doctors in this country. And our training of our medical and our healthcare professionals, not just medical, healthcare professionals in general, is excellent. However, what happens is that because of the absolute, I want to say, the situation at your public hospitals, those doctors or healthcare professionals have to work long hours, sometimes with not enough equipment or not enough medicines, under terrible conditions. And that allows them to leave, and they lured into the private sector. And then what you start having is that those private sector healthcare professionals are also lured into working for in overseas. So we've got a lot of brain drain that happens with the fact that we've got excellently trained healthcare professionals that choose to go and live in other countries.
You have university hospitals are very well advanced in South Africa. Are they? Do they provide enough care and take care of enough people in South Africa? University hospitals.
Our university hospitals are excellent. They provide excellent care, and I cannot stress it better than just saying excellent care under sometimes under very difficult circumstances. But it is again a matter of having enough money to buy in the correct equipment. Um, just as an example, and it's a case that we're dealing with at the moment, and I actually can use that as a very good example. So, for prostate cancer, one of the latest technologies available is robotic surgery. And that would mean that robotic surgery is something that should enter at an academic hospital because you need to train your new urologist in the technique of robotic surgery. So that is a combination of an education grant as well as a facility grant. But at one of our provinces, where there is an extreme backlog of radiation therapy backlog, as well as a prostate surgery backlog, there isn't enough money to buy exactly that equipment for the province to start training new doctors in robotic surgery. And I'm now sitting with a request of a young man, 39 years old, that requires robotic surgery. It can't be done.
You know,
So what are we?
in the United States, that is not a problem. Prostate cancer was well taken care for men. So we have a lot of problem with the breast cancer side. So that is a huge problem here. And then that enough for access to care. Same thing as in South Africa. Tell us a little bit about the besides the prostate cancer for men. What about the other cancers like breast cancer and other cancers that prevalent in South Africa?
So breast cancer in South Africa, in the private sector, again, we've got excellent care. Our patients that do go to private care for their screening as well as their treatment are in fact treated within the international guidelines. The problem with the public sector would be the number of patients, and therefore it becomes a waiting list. And some of those patients have to wait anything between 3 months and 9 months for their treatment within the public sector. And that depends very much on, I want to say, in which province you live. What we also have, and that is in general for majority of the patients in the public sector, is that most of our patients in the public sector are diagnosed with late stage disease. They're diagnosed with late stage disease because at the primary healthcare level, the ability of our healthcare professionals to do early detection and screening isn't there. So patients present already with late stage disease symptoms, and by the time they then are referred to the tertiary hospitals for their treatment, it then becomes a challenge to treat those patients. And that would be for any of the cancers, whether it be prostate, cervical, breast, colon, all those kind of challenges we have for our cancer patients.
That's a worldwide is true. The early detection and the screening is a
Yes.
big challenge everywhere. Sometimes, even if they have access, people don't go and do that, and there's a lot of other factors also play a role. Sure, that's one of the things. But let me ask you a question of what is the if in the United States people, if they get a cancer, usually even a middle class families, they have to switch to the public health because cancer care is extremely expensive. Tell us a little bit the cost of the care in South Africa about the cancer care. If they is it extremely expensive, or they can afford it, or an average middle class. Can you give a rundown a little bit about that part, please?
So your average middle class person, that would be, let us then come back to that figure of 16% of the population, they will access the private sector and they will access the care through their medical scheme, who will most probably pay for the majority of the costs associated with their cancer treatment. The only aspect where it could not be funded is when you start talking about your high cost medicines. That would be your immunotherapies, because it's just the cost is just too high. If we look at a medicine, pembrolizumab, that for instance is not going to be covered for the, I want to say, for more than 80% of your private sector patients, that it will not be paid. So that is definitely not happening. Within the public sector, your cost for your cancer treatment, in fact, is covered completely then by government. um, you as the patient have to, so your out of pocket payments would have to be your transportation cost for your treatment. um, and then also there is a fee attached to every visit, so it's a nominal fee. But even that for many patients could be an extreme out of pocket cost. What also happens in South Africa, and that's whether you private or public sector, is that many of our cancer patients are faced with the fact that they have to stay out of work for the duration of their
Mm.
cancer treatment, and not all the employers are really sensitive to this, and therefore patients have to go onto sick leave, or patients actually lose their jobs. So that is not protected within our labor law. Unlike countries such as, I think it's the Philippines and Chile, and even if I think Brazil, those countries have made provision within their legal system to actually protect cancer patients and cancer treatment. And that is something I think that we would like to work towards.
That would be excellent advocacy for you to make sure that fight for the legal rights of those people that who are sick. They cannot go back to work, and they are not covered for that. Some kind of a disability kind of a
Yeah.
situation has to be there. So yes, that's a good news. At least that people with the afflicted with the once they are diagnosed, they can be covered quite extensively by the public system, and the private system is also is decently very good in that sense that if they are diagnosed and once they are diagnosed, that is accessible very easy to get access to those resources, as you say.
Yes,
That's what you're saying.
yes, yes. I mean,
It's not that okay.
yeah.
Let us talk about. I saw your column, one of the columns that you mentioned, medical legal claims. we have a we have a huge problem with the fraud, the claims, and the Medicare budgets here in the United States. So, what is a medical legal claims? A little bit. Tell us, expand that idea about the medical legal claims.
So patients that are in in the private sector, they at least, I want to say, they've got their own insurance, and they can pay if there's a claim against a doctor for any wrongful procedure or anything like that. They can utilize, I want to say, their own insurance systems to actually pay for that. However, patients that access the public sector haven't got that ability. So when there is a claim against the government for any wrongful treatment procedures or whatever, it then becomes a medico legal claim that the government has to pay for. So that whole investigation and court procedures, etc. So there's a lot of that happens. And what we find in South Africa, and the Auditor General, in fact, has highlighted this is one of the problems within the healthcare system. That if you look at the budget expenditure, that a great percentage of the budget expenditure goes towards medico legal claims. So one can then start analyzing that and ask, but what are the reasons for this? Is it
Bunch of lawyers,
well,
attorneys, lawyers, right? The legal system.
that's right. But also, one need to ask the question: isn't there, for instance, the fact that you've got healthcare professionals that are overworked, that we haven't got, that we've got hospitals that cannot function properly because they haven't got all the correct equipment, or so there could be many, I would want to say, reasons why certain things are happening, and we're not necessarily addressing the root cause of the problem.
There must be a legal framework. They need to address that part to do. That's one of the advocacy for you also in the list of large number, lot of advocacies you have.
Yes.
That's one of them we need to add.
Yeah.
The the question that I have is a little bit about my friend. Actually, I work with a South African gentleman. Not I interviewed actually on my program. South African gentleman. He's in the United States. He's in Knoxville. He manufactures the cancer equipment. So one of the state of the art cancer equipment he manufactures is from South Africa. Nick Schroeder, his name. So his company name is I I'm just not remembering the name exactly, but he's one of the pioneers in the proton therapies and the electron beam therapy in this
Yeah.
country. So I interviewed him on my podcast actually.
Okay.
But so South Africa had produced one of the best. He was educated in South Africa, so that's he producing a very quite a bit of. Actually, I'm not that far from your Elon Musk. So your South African
Yeah.
native here.
Yeah.
His factory is not that far from here. So we are all great people came from South Africa. In fact, so but the access to care is still with all these talent and the smart and the educated people around you, and still the access to care that must be the challenge for it seems to be a challenge. So there is a people like you advocacy program plays a crucial role in particularly for the cancer was a deadly disease. So that what are the things you do usually to further advance your advocacy program?
So the Cancer Alliance, and that's the organization that we have in South Africa, is I want to say the mouthpiece for cancer advocacy in South Africa for our cancer patients, and we're an umbrella organization bringing together more than 30 cancer nonprofit organizations as well as individual advocates. And our purpose is to make cancer a priority disease in this country, for government to recognize it as a priority disease, so that we can redirect, I want to say, funding towards cancer care, because it's not only, in fact, it's not only just about cancer care. It is about building a healthcare system at a primary healthcare level that can look at the person as a whole and that can deal with the person from at all levels and then have appropriate referral pathways. So for us to do that kind of advocacy also requires funding. And funding for us is crucial. At the moment, nobody is funding us. So most of our work is being done voluntary. And voluntary and working hard, I want to say 365, 24/7, that kind of analogy. That's what we do because we have to continue putting on the pressure on government.
You have a big diamond, as I saw some movies, you have a big diamond, diamond, and the gold mines are there in South Africa. So there's a lot of foreigners and expats come down there and do the labor work. How their healthcare system, if they get a cancer or something, or they are taken care by public health system, or they're left for dead.
That, I think, is one of the biggest problems and biggest challenges that, let me say that Africa has got, and particularly South Africa. We cannot at this stage of the game even deal with the scourge of our own people.
Yeah.
So the question remains, how are we going to deal with migrants? And that and everybody is running away from it. Nobody wants to actually look at it. We have got a lot of African countries that is starting to look at also improving their own cancer care, but that still is also going to take a long time. And we've got a lot of people from other African countries who cannot access care in their own countries
They come to.
that come to South Africa, but they then have to access the private sector. And there's many of them, and they do. They access and they pay. They pay the what I call exorbitant
Is
fees.
it?
They pay for it. But as you say, the problem remains about that migrant worker that is now diagnosed with a cancer. What happens? If that person doesn't have the money, and what will happen is that if that person accesses the public sector, that person has to pay according to medical schemes tariffs in the public sector. They can't afford it. So yes, it is actually a reality. Those people are sent home being whether either you stay in South Africa or sent home to your own country to die. So it is a conundrum that we really will have to start looking at from an African Union perspective. And I also want to say from a World Health Organization perspective, to actually look at what systems are we going to put in place for cancer care for our refugees and for our migrant workers.
So the Millennium Fund, that is a, for we all come to know about a Millennium Fund, is a very well well allocated funds for the AIDS and tuberculosis. I think that's are all well funded from the United States and the World Health Organizations, right? That is particularly came from the United States under George Bush leadership. It came a lot of funds were allocated during that time of AIDS. Is that right?
That's correct. Yes. So there's lots of there's lots of funding that pours in for HIV/AIDS and TB, but there's no funds that are pouring in for cancer. What is starting to happen, and that at least is, I want to say, progress, is that because of the linkage with HIV/AIDS, cervical cancer is starting to getting some funding from an HIV/AIDS perspective. And that, at least, as I say, is progress. However, there are many other cancers that also has to get the attention, and we actually need to bring it to the attention from our international agencies, our philanthropic organizations, that cancer is not one disease.
Yeah.
Cancer is more than 300 diseases.
Yes.
And each cancer for each person is different. So it is not as easy as a one medicine, or, one size doesn't fit all. And that is the challenge in exactly with cancer and cancer care. So if one look at how do you start building your health system to provide timeous care, it is an expensive exercise, and cancer is on the increase.
You know, if South Africa is struggling about the cancer, one of the advanced countries in Africa, think about other countries. So give us some rundown on the rest of the Africa. What is the situation in African countries, the cancer situation there?
Well, let me say this to you, that I think that in the whole of Africa, cancer is a major problem. Again, not necessarily being addressed in the same manner. I think, yes, as you say, South Africa is in a better position and we have got, from a healthcare professional perspective, as well as equipment, as well as the access to medicines, cancer medicines, we are, I would say, the best off. The other countries, if I look at, for instance, Kenya has got, and where they are far ahead from South Africa, they have got what they call a National Cancer Institute, and their Cancer Institute coordinates their cancer program, which is what we don't have in South Africa.
So Kenya is doing
Similar,
very well in that sense.
they're doing well. They're
Okay.
doing very well. And similarly for Uganda, and I also know that Botswana are also starting to look at it from a far more integrated perspective. And that is unfortunately what South Africa doesn't have. We don't have that integrated care perspective, because we're still talking about the public and the private sector. So your African countries, and then Rwanda is your other, I want to say, other star that is really starting to focus again on integrated care systems. I know Egypt is also doing well, Morocco. So there's many of your African countries that are literally working towards that integrated care. Obviously you're going to have some countries where care is just very minimal, and lots of patients still are not getting care, or either that they have to go towards India for treatment, or other countries where they go for treatment. I also know, for instance, in Nigeria, there's lots of people from Nigeria that prefer accessing private healthcare in the United Kingdom. So that's kind of like what you have in Africa.
Very interesting. You gave a very rundown of the whole African system there. So if some of one of the final questions I'm going to ask you about the complementary integrated care that you were talking about. So people that with the cancer, that there's a lot of depression, a lot of other services they require. particularly some of them may prefer complementary services like integrated health, like Ayurveda or other services. How the system responds in South Africa, that kind of a need for that kind of system. How, what is the mechanisms you have, or people don't even pay attention to those kind of complementary services now at this time?
So they, I want to. So in South Africa, I think we also need to say, and that actually happens within Africa. The our by very nature of our people, we've got many people that access traditional healthcare. So they go to their traditional health practitioners as a first point of care. And then, and therein lies another, I want to say, challenge. It's not a problem. We need to marry a Western system with the traditional African health medicine system. And that is where we need to find that collaboration and building of capacity within the traditional African medical health system or health system, that you make sure that you build the capacity of those health practitioners to also refer towards the cancer care specialists, but also that there can be complementaries within this, that can be used. So from I want to say a Western perspective, it is always important that when we talk about cancer care, that when you want to utilize a complementary medicine, that it always is done in conjunction with your healthcare professional. And that is what is very important. And I don't think that we should actually just discard and say, no, it shouldn't be available. Because people grow up in communities with systems that they trust. But what we need to do is we need to embrace those systems and let the systems work for the individual. And that is, I think, going to take us a bit of time still, to actually get to that point as well.
So,
But
Salomé Meyer, you are a true advocate. The South Africa is a blessed to have you advocate like you to for cancer, their care. So I'm honored and privileged to talk with you. It's a thank you so much for joining with me in this hour.
thank you. It's been my pleasure, and best wishes to you and to all your
By
listeners
the
there in
way, happy
Silicon Valley.
Bandana Day. That's I don't wear a bandana, but I'm wearing a hand bandana. Happy Bandana Day to
Thank
you.
you.
Thank you. Today is a
Thank
happy
you. And
Bandana Day, right? That is a Cancer Day, October 25th. Right?
we don't, we have to be honest with you, we have so many cancer days that you kind of, I want to say, get confused of which day
Which
is
one
when,
is that?
that kind of thing. But yes, thank you and very much, and happy Bandana Day to you as well.
Thank you.
And have a good day.
Thank you, Salomé. I'm truly honored. Thank you. Thank you for
Thank
joining.
you. Thank you kindly.